Okay, hello and welcome everyone. I'm Raj Kumar. I'm the president and editor-in-chief of DevX. Really delighted to be asked to moderate this session, and I welcome you all virtually to this Global Health Council event. I miss the days when we could do this in person, but what's great about it is we get to have a really international group with us today, which is fantastic. I'm so glad to be here with Lola Dare, who's joining us from Nigeria, Paul Farmer, who is joining us from Rwanda. Vanessa, I'm not sure where you are, but Vanessa Carey is with us as well. I'm here in Washington, D.C., and we're going to have a really robust discussion on what I think is a pretty critical issue at this moment in the pandemic, and that is this issue of global health security fatigue, and kind of where are we in getting a global consensus and movement around investing in health. I remember back in 2017 at DevX, we did some reporting. We did a report where we went and interviewed 40 global health leaders. Maybe some of these panelists were among them. I know Dr. Fauci was one of them. And we said, what are the biggest threats, global health security threats facing the world? And the number one was a influenza-like pandemic, respiratory disease of some kind of virus. And I mentioned that only because it wasn't really a big surprise to people on this panel, to global health leaders, that the world is vulnerable to pandemics. And yet all of those calls to strengthen health systems, to invest more, maybe fell on deaf ears to some degree. Here we are, a year and a half, 2 years into this pandemic, and still we see massive inequities. So I think the purpose of this panel is to really ask ourselves the question, what is the story we're telling around global health security, and is it working, or is there a better story we should be telling? And we've got a fantastic group to get into this conversation with us, and maybe even a little debate, which would be great to do. We've got Paul Farmer, who is known to all of you for his work in Haiti, in Rwanda, and all over the world with Partners in Health, which he co-founded, and of course is a professor at Harvard Medical School. We have Vanessa Carey, who's the co-founder and CEO of SEED, which is a leading nonprofit organization that really invests in health systems at the level of people, investing in global health workers and doctors. And we've got Lola Dare, who's the president of Chestride Global, who is a community physician, an epidemiologist, and a global health advocate, wearing many different hats. It's just fantastic to have all of you here today for this discussion. Maybe, Paul, I can just start with you. We're a year and a half, 2 years into this pandemic. What do you think about the story we're telling, the message we're saying around global health security? Is it working? What else should we be saying? How do you feel about the language we use?
Well, I don't want to seem. First of all, I thought Lola was going to go first. No, but I'm just going to. I'm going to just say the good thing, by the way, about these webinars is you can convince yourself you're just in the living room with three friends, and then you kind of and then you
hold on to that too.
But I think the proof is in the pudding that it hasn't worked. And I'm sure a more sophisticated and nuanced analysis would say, well, it's worked here and not there. But I just want to get it out there, pretending that I'm in a living room with three people I admire, and say, I think there's just a lot of downside to the entire structure. And I'm not saying there's no upside. I mean, I would be in a minority probably anyway. But, just take what's going on right now with Omicron. We know that the border closures, they don't work to stop an epidemic. You go to the source or the sources. But then again, you also know the political expedients that require prudent and responsible political leaders to make decisions like the ones made even here in Rwanda. And I think it's okay for me to say, I'm up at the University of Global Health Equity where Raj, you visited, and our dean happened to be coming back from Zambia to Rwanda on the day that the Rwandan said we're going to, have a quarantine requirement for anyone who comes to these countries. Now, that's not the same as a travel ban. The dean survived his quarantine quite comfortably. He probably got a lot of work done and chilled out. And he got here in time for our white coat ceremony yesterday. But, going to the big metaphor, I think the question that we're getting at least I'd like to throw it out to my friends here, when does reparative or social justice language, or even invoking mercy, pity, sympathy work better. And then I would just say one thing, and we'll go back to this. During the Ebola outbreak in West Africa, and Nigeria, and Lola knows a lot about this. Nigeria, did spare. Lagos was spared a major outbreak, but why was Lagos spared after Ebola reached it? And it was spared because they integrated prevention and care, not because they failed to shut the border. And that's why there wasn't a big secondary epidemic, and most of the patients treated in Nigeria lived, whereas 80% of those who fell ill in Sierra Leone, Liberia, and maybe Guinea too, did not live. So, and I just wanted to add that personal point. It just feels awful, to show up in your home country, for example, or any other, and get turned away or shunted in. And what did it yield for those Americans, for example, going back and forth between one of those three countries in West Africa, not Nigeria, but Liberia, Sierra Leone, and Guinea? What did it yield? This intrusive monitoring. It didn't yield any diagnoses. The ones that were made in the United States after that were self-diagnoses made by physicians or others who were recording their own temperatures. So I know that's kind of an extreme example, but I wonder if our community, our development and health and social justice and international global health community, can't do better than at least crudely use security approaches to pandemic disease.
Yeah, these security kind of language or framework, Lola, it tends to be very divisive, right? It's about protecting us from them, especially in these international fora here in the United States. I think when global health security is invoked in the US Congress as an argument for funding of global health, we don't want the diseases from over there to come here, therefore we should invest. What do you think are the other arguments, or what do you think is missed when we focus so much on security as the language around global health?
Thanks, Raj, and thanks. Hi, everybody. It's great to see you again. Let me first say that the well-intentioned name of use of security initially, it was a well-intentioned use. It wasn't meant to be us against them. It was well-intentioned to protect the whole world, to make the world secure. There was equity in the language. There was social justice in the language. We belong to several platforms, including the one in Georgetown University, calling for an international treaty that allows us to live in a safe and secure world. As we, as advocates from country level, advocated for the SDG, we advocated for one world, secure from all threats, internal and external. So let's start from there, and let's recognize the well-intentioned use of security. But sadly, the word security has significantly shifted away from whatever we conceived it to be. And are we going to shift it back to base? At the moment, the word security sounds like a military term of war against viruses sometimes. It sounds like war against them and us sometimes. And the them and us is not just Africa against the world. It's also the haves against the have-nots in all countries of the world. I've watched the Americans struggle with different kinds of inequity. And so I would like to pose to Raj, if you were to ask that same question again of top global leaders, what is the threat? What are the threats of the world? I think the first two words would be equity and poverty. We have actually just rebounced them, and we need to drive out the word security and put back the word equity, poverty, and social justice into that system. And that's where we are now. We're no longer trying to secure the world for all of us. We're trying to secure the world for some of us. So global solidarity no longer means all of us. Global solidarity has taken a different meaning. And it's very upsetting to see even Africa think we're going to produce our vaccines by ourselves. These guys don't know how to do it, and they're not going to be able to do it by themselves. There's a solidarity of doing things together that we are losing. And that word security is helping us to lose the concept of global solidarity that is value-based, justice-based, and equity-based. So we are losing that. And it's sometimes it's a dilemma to say, where do we restart the language? How do we restart the engine? Because the big powers of the world, the economic powers and the military powers, and those that actually have the machinery of global voices in their ports, are not going to listen to us without us doing something very radically different. So we need the poor farmers again. We need that kind of activism again that puts the right words back into the global discussion and really allows security to take a backstage at the moment until we can come back to what we mean by security in the first instance. We need to put justice, we need to put equity, and we need to say we need to defeminize poverty. We need to put those key languages back into the discussion that we're having now. Let me just add one thing that we need to think about as we do that. We need to think about the infodemic. 80% or 90% of the impact of what we're seeing is the result of a largely ignored yet impacting infodemic of COVID and health. Is this what we need to deal with? I think we have so many questions, but I just like to put the infodemic on the table and its impact on helping us to shift from a well-intentioned global health security and solidarity to a now totally fragmented and disgraceful act of security, which is now poverty-driven and inequity-driven.
Vanessa, you've spent your career thinking about the inequity that exists between global health workers and workforces in some countries and others, and try to use training and try to bring education in order to build up stronger health workforces. What arguments have worked to do that? I mean, are you using a security argument, or have you abandoned that? What do you think actually works to get people in places like the US and in Europe to care and to really invest and to see this as one global health system, to see poverty and inequity as their issue too?
I'm glad you asked me a slightly different question, because I was going to say, after Paul and Lola, what they said, right? Like, I mean, I think that I'm realizing you're going to have three, fairly shared minds. But what I actually think that speaks to is the reality that for those of us that have spent a career thinking about this, and we're coming to the same conclusion. It means we're not doing something yet, and something that is critically important. And securitization, it falls in definitions, right, to some degree. And I will come to answer your question a little bit backwards, because the reality is it's how we define security that matters. Because right now it just creates a political agenda and political expediency, and it allows for political tools only to kind of follow along traditional lines of protection, as you outline, right? It becomes more of that nationalist, we must protect, and it's security. And when we think of security in the political agenda, we think of it in terms of our national security. The reality is security can be defined. Actually, human security is on an individual level, it's on a community level, which folds into a national level and ultimately into a global level. And when we talk about global health security, global is the key word there. It's about the connectivity of the world that we live in now, and it's about the fact that we share this planet. You look at the climate change agenda, that's a perfect example of a global public good or opposite, right? An externality. The damage of climate change is felt by all. And if you look at sub-Saharan Africa, they are the smallest contributors to climate change, and yet they are one of the most hard hit and vulnerable in this moment in terms of the impact. And so we have to start reframing ourselves into a global mindset. And where this comes in, and this comes into the work that we do a little bit, is that the reality is that there's a value shift that has to happen. So when we talk about security, we actually, and the definition, the expedient definition, or you can break that down into what it means to have individual security. Because an individual's main asset is their ability to go to work. And if they're not healthy, they can't go to work and they lose their main asset. And that just flips that cycle into poverty. It flips into a whole, kids don't go to school. The whole cycle gets interrupted. And so what we're really talking about is what we value, and what our leaders who are in the positions of power and making decisions value, and what we as a global community value, and where we're going to put our time, our money, our bandwidth, our investment, and what the power brokers or holders are willing to give up, if you will, to be able to create that equity path forward. And the reason this matters is because I've spent almost 20 years now trying to get people to train a health workforce and to invest in people, because the healthcare workforce is the front line of our COVID response. When we don't have oxygen, when we don't have drugs, when we don't have functional health systems, but there are health workers there that are caring for patients, they are our primary asset. And the problem with this is that we've lost 115,000 at least in COVID. That's over 1 million years of training in aggregate and billions of dollars of training in aggregate. And when we think about preparing for the next pandemic or building capacity to produce vaccines on a continent, if you don't have that, we're only digging deeper and deeper. So we've actually found that to convince people of the power of investing in the health workforce comes very fundamentally to the value of health, to the value of well-being. And what does that actually mean? And if you get really existential about our human survival right now, which is everything we're talking about, COVID pandemic, climate change, poverty, equity, it's about the human experience that can be shared on this earth. It comes down to what we value as a community and whether we are going to parse that out or we realize we all rise, right? When we all do well. But we have to shift the values in many places to begin to shift the investments and to begin to close these equity gaps. And so as we talk about investing in the healthcare workforce, I can say that we've trained almost 28,000 doctors, nurses, midwives in 8 years. It's a powerful number, right? But it still doesn't compel people to necessarily put the money, the time, the investment, and to wade into the complexity. And I think when we talk about what it means to create jobs that recognize women formally, to be able to put money into a system that closes some of the poverty gaps because you get formal employment, you can actually create a tax base, there's data that links it to economic growth, then we've begun to get people to sort of see the power of the investment. But I think it fundamentally comes down to this incredibly existential moment. And if we're going to have the courage to make the decisions that benefit us all and close these equity gaps, because it really is fundamentally a value system. We have people spending billions of dollars racing to go to space when that money could be worrying about, food insecurity and health and all these other things. But I'm so
it does take courage. I'm glad you used that word. And Paul, I thought you were giving us a tour of the University of Global Health Equity there for a minute.
Sorry,
which would have been great, actually. And it's a good segue because it took some courage for you and Agnes and your colleagues in Rwanda to say, you know what, we're going to put up a world-class university in rural Rwanda. And we're going to put it up here because this is where it ought to be, to train medical professionals for working in the context where the need is greatest. And I guess you're famous for not giving in to the realities of lack of funding. You talk about socialization of scarcity in our sector, where we tend to think, well, there's just not enough out there and we better live within our means. I guess I wonder whether you're at all surprised by the level or lack of level of ambition at this moment in the pandemic in the world for strengthening health systems, right? I remember at the very beginning of this period, we thought maybe this could be the moment when the world sees how important health is and everybody stands together and says, we're only as strong as the weakest health system. How do you feel like we landed at the point we're at?
Well, I'm thinking that we're still falling or moving up, either that we haven't landed yet. And so, those conversations that we had, and many did at the beginning of the pandemic, I'm not giving up on those. I think these crises are, and this crisis, the biggest one, is still a chance for us to instruct people much more about the importance of health systems. And if I could just step back, I keep going back to that Ebola experience. I don't know why, but, and it's still going on. We're still there, as you know. We're still strengthening the health systems, and that means like building a new district hospital, refurbishing another one, opening up shuttered clinics. So it has the same definition as the one we're all for using. But they had a rank familiarity in Sierra Leone, for example, with lethal pathogens before Ebola was recognized. But there's also something I saw now since Ebola and since COVID is there's a lot more familiarity among the population with what could be gained, for example, through social distancing or the hope for a vaccine. There's a great deal of fluency there that I did not see in 2014, right? People have gone through a lot. Now they've lost a lot, and back to Vanessa's terrible metric, in that epidemic, with a couple of people in Nigeria as well, and elsewhere in Europe, about 1,000 healthcare providers died. That's a huge number in at least two of those countries, Liberia and Sierra Leone. And there are probably only, and Vanessa may know this number from Liberia or Sierra Leone better than I, but in Liberia, there are probably only about 50 physicians practicing in a country that's the size of, for the Americans, Ohio. And that was the way it was before the epidemic, and that was the way it was after everyone left. Still about 50 people, which would be the equivalent of about 6 people in Boston, 6 physicians in Boston. So what do you have to do to address that? You have to build nursing capacity. You have to build medical capacity. You can't just do these weekend workshops, that, unfortunately, a lot of USAID and other international donors have invested in. These are not the way we train clinicians. And for that matter, I'm including, of course, psychologists, social workers, and community health workers. So, I do think that we're still facing the possibility of a much broader understanding. And to just close that with one little personal anecdote, I was finishing a book about Ebola when COVID hit, and I had been in discussions with my editors. It was like a fancy New York press, not the usual academic press, that I would publish with. And they were saying, look, you can't use words, acronyms like PPE, and people don't know what social distancing is. And, what's the difference between isolation and quarantine? But they stopped saying that after COVID hit, because it said, hey, now everybody knows what you're talking about. You can leave that stuff in. Now, I know that's a very sunny way to read, to read our possibilities. Now, after 2 years, and we're still stuck in this rut, we're having to explain that social security is not the same as military security. But I'm going to retain some optimism there.
Lola, how do you feel? Do you feel optimistic? You're in Lagos right now.
I see an opportunity. Even if I'm not optimistic, I see the opportunity for us to move towards that optimism that we almost have. Because it would be really tough if we all gave up. And so we have to continue to look for opportunities. There's an opportunity because thanks to social media, even in our villages, somebody knows what COVID is, somebody knows what PPE is. We're working with 10 communities at citizens level in Nigeria. And what we're asking them is citizens' demand and citizens' action is a starting point. That's what we did with HIV/AIDS. We didn't wait for the world to save Africa. We started community by community, citizen by citizen. And so we need to first and foremost, we're building citizens' understanding and citizens' voices using the same platforms that gave them the wrong information. And so we are addressing the infodemic. And we're saying to them to say to the whole world, what is not available is not equitable, and there's no vaccine hesitancy in Africa. There's no vaccine resistance in Africa. There are systems that work, and that's what, so citizens need to raise their voices at global and at country level. This is the success of HIV/AIDS, the power of the citizen's voice. That second power in the citizen's voice also means that we're not going to sit down in Lagos and say we are going to speak from Lagos to New York. We're going to work with partners and going to try to amplify our voices at the global level and work with like minds to see that those voices are going up there. But I think this is the time, the moment of optimism for me after so many years of work is the opportunity to address global partners and they tell them they're doing something wrong. We've just never had the opportunity where the whole world is saying the global community is kind of falling short. Even the IHP Plus IHP Plus couldn't do that as well. So the global community is kind of falling short on what security means or what global health means. And so we're going back to the global community and saying, is the connectedness of national health systems, that's global health. So your system is not going to survive if mine doesn't survive. Your people are not going to be safe if my people are not safe, because there's an interconnectedness of our economies, there's interconnected of our well-being, and there's interconnectedness of our world. Now, that may sound like some of my friends on Twitter call it some moral persuasion, Mary Slessor kind of advocacy. So be it. We have to interface in that world called global solidarity. At the moment, our global solidarity definition are too economic-based and too power-based. They're not value-based assets. So we're also looking to look at redefining global solidarity as value-based assets that allows other things to come into that discussion. Are we going to do it in 5 years? I'm not sure we will, but we're sure going to give it a try. And so it's redefining citizens' voices, redefining global solidarity, and taking the opportunity in this terrible yet wonderful disease called COVID, to reestablish national health systems as the focus of attention and primary health care as the approach to do it. And so we see both an opportunity and a risk, but I think it's best to flip on the side of the coin that says there's an opportunity, let's take it.
There's so many important points you just made there, Lola, and I want to get into all of those. I do want to mention to those who are following along, if you have thoughts, comments, maybe you've got an idea for what the framing should be if it's not around global health security. We'd love to hear those, and I think there's a way you can put them here in the comments, and we may be able to see them. So please do that. Vanessa, what's your take? I mean, Lola's talking about primary healthcare. Okay, that's a core theme that many in global health have focused on well before this pandemic. She's talking about health system strengthening. That's right where you work as well. All three of you work in that space. Again, a core area. We learned a lot in Ebola from that, the needs for those strong systems. She's talking about a values-based approach. I mean, you know the political side of this well, and you partnered with and worked with government agencies. What do you think actually resonates? What do you think works to get people to see these things in the way we in the global health space see them as so paramount?
I don't think there's any one thing, because every individual hears something differently. It comes from a different frame, if you will. I think the reality, though, and the things that can be said and said effectively and honestly, is that we've made progress in the last 40 years, certainly. When we put our time and attention to things, we've been able to make progress. We've reduced maternal mortality, and we've done better on childhood mortality, and we were reducing TB deaths. And, PEPFAR was an extraordinary large scale. But I guess what I would say is that we've made progress in the last 40 years, but if we made the progress we should have made, if all those billions of dollars in time and energy had come together in the right way, we would not be losing ground in a global pandemic. We would be much better prepared to take it on, and we would be able to do this much more agilely without losing the number of people that we've lost. And I think without sort of the scope, without the kind of crisis that we are finding. And if you look at Ebola, for example, going to Paul's example of Ebola in West Africa, we put about $19 million into Liberia, specifically on health system strengthening after Ebola. And it worked for a couple of years, and we built capacity and networks were built up. But by 2019, Liberia was in the bottom quarter of countries for pandemic preparedness. This is a country that was 5 years out from one of the largest global outbreaks that had been seen, and by sort of various pandemic measures had been done. And so the reality is that we've done this piecemeal, we've done this disease focused, and we've done it, frankly, on kind of donor agendas, not on actually the solidarity agenda of the places we're trying to build these health systems. And so if we reframe behind our partners and say, how do we do that primary care prevention network? And by the way, our COVID response should be thinking this way. Every dollar we put into COVID responsiveness, we should be thinking about how it gets leveraged to build a primary care network, because our ability to have community health workers, in the community and tracking COVID is the same network that one wants to use for referral, frankly, as for primary care or maternal mortality. And so I think that what needs to change right now, we've been really trying to tout, and this is why we've been working with the Africa CDC and others right now to think about how do you create an entire framework for investing in the healthcare workforce that is owned by the countries that are in need of this health workforce, that appropriately forecasts for that country what they need, costs it appropriately, changes timelines to 15 to 20 years. None of this 3 to 5 year timeline. Let's take the time we need to do it right. Builds out the local capacity for domestic financing, again, not in 3 to 5 years, but in 15 to 20 to get the GDPs up and running. And to be able to then build metrics of success that aren't just the outputs of who you've trained or how the health system is performing, but is there social inclusion? Are women in positions of leadership and being paid? Are we paying our community health workers? Are we seeing economic growth and more kids go to school? And sort of what is the social metrics of this success? And I think that if we can push governments to understand that possibility, and this is where PEPFAR has been very successful, right? $15 billion announced for a single disease to really focus and build capacity. And it rolled out, and it didn't tie itself to only 3 years. It said, we're going to be here for the long haul. PEPFAR's not perfect. There's plenty of places it could be improved. But what it did do was begin to show what can happen when we have the imagination and the willingness to change timelines, put in big money, and think about how we can really build community-based systems of care delivery that can focus on prevention and really and be able to link the prevention to the treatment and the care as well. And I think, and stop the narrative of we shouldn't be audacious and ambitious, because there is no reason in 2021 that the countries that have these fractured healthcare systems, there's no reason in 2021 that we can't close that gap. We have all the technology, we have all the scientific know-how, the resources are out there. It's all a question of political will. And I think we as a community have to challenge that.
Paul, go ahead. Go ahead.
I just wanted to say, after just hearing what we've said so far, I already hear at least 4 or 5 paradigms that at the very least are complementary to any kind of security paradigm. And it's clear that the 4 of us, I'm not speaking for you, but I know that you feel the same way. 4 of us are comfortable with a social security paradigm, the one that Lola mentioned, that really started this well-intentioned. But in addition, we have all these complementary paradigms. We've already heard the health and social justice paradigm, which could be thought of as a rights-based paradigm. And we'd be mistaken to dismiss that because it's the most expansive notion, right? The right to health care, which is even less expansive than the right to health. And so to give up on that would seem to be a big mistake. We have the economic development paradigm. In other words, and this is very popular, as you've noted in some of your writing as well, with heads of state, right? You want to break the cycle of poverty and disease, invest in health. I mean, look at Rwanda. They put, of course, no wonder they have the steepest declines in mortality ever documented at any time in human history. They put 20% of their public treasury, into health care delivery for that reason. So they're trying to use that really economic paradigm of break this cycle of poverty and disease. And we've got the public health stalwart types, public goods for public health, which always include a kind of security paradigm. That's why there are certain laws around tuberculosis and other pathogens. And that's all before using the more selfish and troubling security paradigm that says, hey, if you don't help them, you're the one who's next. You remember in the early years of the AIDS pandemic, people we know, including some friends, were writing papers about, hey, there are 15 million Africans, youth, about to be orphans and with AK-47s and all kinds of absurd things and also insulting and problematic in other ways. But, did that really spur people, or even George W. Bush? Was it that led to PEPFAR? I don't think there's any evidence for that. So even before we get to the health security paradigm, there's a half dozen more that are, and they're complementary. It's not like we have to only use one paradigm. It also depends on an audience,
Do you think there's a good debate going on, good conversation going on in the comments section, which I welcome all of our panelists if you want to take a look and hear what people are saying. But one of the questions Carolyn Reynolds poses gets to this theme around the global health architecture. Like, we're talking a lot about the arguments that are made to political leaders. Do we need a different architecture? Do we need maybe a new PEPFAR for COVID, as she's saying, or posing, or do we need a different institution? Do we have the global health architecture, or is it really about just what arguments we need to make? How do you all see that? Lola, do you have a feeling for that?
I do have a feeling for that. Hi, Caroline. It's great to hear you and to read your chat. I'm not sure it's about the architecture. I think it's about the behavior of the managers of the architecture. Another PEPFAR would be valuable because another COVID-like PEPFAR or a PEPFAR-like COVID would be valuable because of the resources it will put onto the table. But would it change behavior that makes the impact sustainable and meaningful to the last mile? I doubt it. I think we need to actually have a new discussion on how we on that issue of behavior. It's something that it's always a very difficult discussion, but we're at the stage where we know the technology, we know the vaccines, we develop them now in 6 weeks or less than that. But now when it's time to roll it out, our bad behavior comes back again to haunt us. I think we need to look at a discussion on what have we learned from HIV/AIDS? What have we learned from polio? What have we learned? We've learned that to get to the last mile, for it to be sustainable, we need to build health systems that are robust. How do we define the health systems? The health systems have to be context specific. We cannot define it from New York. Neither can we define it from Geneva. It has to be context specific as defined by alma mater. Country economy can afford it, people are included, it's gender sensitive, and it's multi-sector. One of the things COVID has taught us is that a health pandemic or a health epidemic is not going to sit in the health sector. It's going to affect transportation, it's going to affect travel, it's going to affect food security. And so that holistic approach is not something that we in the health sector can address on our own. So I am a proponent of, I strongly support a health and social protection approach that allows us to put rights in the middle of the discussion, but also not be naive to think that all the actions that will help us are in health. Two, I think we need to begin to respect the diversity of our world. The diversity of our world means that people experience things and respond to things in different ways. Three, I say to our donors at country level, thank you for the MDG, but can we take it on from here? Can we lead from here? Can we take decisions from here? It's also a failure of donor investments if countries cannot lead. And I say to the country leaders as well, it's also a failure of country investments if our leaders don't have a voice. So there's much more than new funds. I think there's a degree of new definition of solidarity and consistent behavior towards alignment, and so that's the definition of solidarity.
That aligns a lot, Vanessa, with what you were talking about before, right? This idea that maybe a lot of our investments in global health over the years have been siloed, disease specific, or kind of piecemeal, not in coordination with the government. They've been sort of one-offs. How do we get past that?
Mm-hmm. Well, I mean, I think this is the silver lining of COVID, if we choose to take it, I think, is the reality that what we have done so far has not worked, or we would not be, I think, in the situation that we are in right now. And what has been made deadly evident is that while all these investments have been made, COVID disrupted services that were already so fragile to the point where TB deaths are now up for the first time in a decade. We're seeing disruption in HIV services. Maternal mortality has been disrupted in a number of ways, and it's going up across the board. So you've lost your essential services, as well as we're scrambling to be able to respond to COVID. So I think that, and by the way, the US has plenty of vulnerabilities, as well within its own health system. This is a universal challenge, which is where I think that values question kind of comes into, of sort of, when are we going to learn that we are just our own worst enemies if we don't just shore up and make this investment of strong, robust healthcare? And if we invest in the health system and the strengthening of the health system, we can tackle COVID and maternal mortality. We should have that capability. We should, in fact, Paul and Partners in Health has done terrific work that they've documented and written about the power of using the PEPFAR money to actually build out primary care systems and the strength of how you enhance all care when you do that. And so I think that, as donors, we have to think about how we stop sort of disease focusing, how we have our own personal agendas, how we come together behind the countries to support their agendas. And I think one of the things we often forget about too is the importance of building capacity at all levels. So beyond just doctors, nurses, midwives, community health workers, you need capacity at ministerial levels. You need technical capacity. We need, and some of that already exists. We just ignore it and assume it's not there, and have created a narrative of, well, they can't do it. And I don't think we have to kind of, people always say build back better. I think it's build back transformatively, because what we've been doing hasn't fully worked. So what are the course corrections we can make? Because I think COVID's our new, unfortunately, I think this is our new reality. We are going to have another global pandemic. So we can't just kind of stem the tide here and now. We have to actually fully change our systems and our ways of working. And I think that we should be honest and okay with the fact that we've done a lot of good, but it hasn't quite worked in the way that we wanted. So how do we course correct? And that's going to actually involve giving up some power in some ways to gain a different kind of power, which is our well-being and global well-being. And and I think in a time where politics are being, and I want to go back to what Lola said about the infodemic, right? Our inability to discern the truth in this world today and to have actual fact and alignment around shared reality is one of the greatest challenges we have, I think, to be able to do a lot of this. Because even if we have the right intentions, governments are terrified of being voted out of office by the folks that live in their own alternate reality of Facebook and things like that, which makes it very hard to make the courageous and right decisions.
Mm-hmm.
Paul, I want to get you back into this. One of the things that I think is so inspiring about the Partners in Health story is that you haven't waited around for the right political environment or for everyone to agree with you. You've sort of said, I see what needs to happen here. Let's just go do it. How have you done that? And how can we in the broader global health community kind of learn from that lesson to say, we're not going to just wait for the conditions to be right. We're going to force them to be right.
Thank you, Raj. And, I see one of the comments from Janine Mitchell about National Institutes of Public Health. And I agree with that. That this should be, I wouldn't say National Institutes of Public Health. After all, there's a lot of public health Luddites in National Institutes of Public Health who also will tell you things about, AIDS treatment not being cost effective or cancer care not being feasible. So sometimes the most noxious ideas, at least in terms of influence, come from expert bodies. But the notion of having national, engagement, or what they call in UN circles, and even sometimes we say this, but I don't, country leadership. When you have a group of people, and you mentioned Agnes, and most people will know we're talking about Agnes Benaguahu. When we started working together, she was not the Minister of Health; she was the Director of the National AIDS Program. And if you look in their in their plan from soon 20 years ago, you'll find in it, all sorts of prescriptions about gender equity, poverty alleviation, and the strengthening of primary care. So the work that's kind of the reason we got invited here, is because they knew about our work in Haiti, rural Haiti. And I want to go back to rural in 1 second. And then they amped their own program, which had these same features, into a national program. So the country ownership, I think it's a sloppy term myself, but engagement with the people most affected by what we're talking about, what Lola is talking about, engaging communities and being rooted, as they used to say, in those communities. So that's kind of when and let me just go back to rural. When we first came here, where this beautiful university is, it's a district with almost 400,000 people, no hospital, but also no doctor, no electricity. That's a clinical desert, right? But the question is, how would we water it? And so sometimes when you're in these wide open spaces, not quite metaphorically, also metaphorically, there's more latitude. So starting an AIDS treatment program in rural Haiti, for example, who's going to object? Not the patients and their family members, not the beleaguered Ministry of Health, right? This is again grounded in the health and social justice approach, as Lola said. That is, is there someone in need? What is being done? Are they being shut out because of their gender, or because they're Black or brown people who are not on the global radar? So it's a pretty straightforward way to proceed. Take cancer, take lack of a hospital, whatever the problem may be, lack of vaccine apartheid. So, I think we do need to steel ourselves against the voices of the critics and the naysayers, who very often are from within our own communities, right? And, how do you steel yourself? Well, you have some North Star, you have some guiding model, and you have those partners with you who are, again, those, as with AIDS activism, people living with HIV, they spurred the whole movement. There would be no PEPFAR if not for AIDS activists.
Mm-hmm.
So I think making those allegiances, knowing who your allies are, sticking up for the equity approach, and in a way that's why we dumped the term global health by adding the term equity on it. Just to keep ourselves honest. And whether it's at a center at Harvard, Division of Global Health Equity, or here, University of Global Health Equity, there's something that keeps you honest by always focusing on the on the vulnerable. And in Rwanda, we've been lucky enough so that they've made that a policy focus. They don't say health and social justice. They don't say preferential option for the poor, but they do say the bottom quintile. They do say don't forget the rural people. They do say don't forget, genocide and women and children. So I think infusing more of that equity language into our everyday approach to this is a way to help us tackle new problems that are sure to come along.
I think the theme that hasn't come up so much yet in our discussion is really patience. And a lot of what I hear from people in the global health space in terms of this transformation, Vanessa, that you brought up, was a transformation to focusing on patients, putting patients first. And when you do that, then you start to think of them holistically, not just about specific diseases. You don't just think about the health system, although the health system becomes really apparent, or the gaps in it, when you ask a patient, how far do you have to go to get access to clinical care, primary care? So I guess I wonder about whether you think maybe the paradigm, Paul talked about a number of them, but a paradigm that could work for our community is sort of a patient-centered paradigm, one that gets back to that individual. What do you think, Vanessa? I see you're reacting to it.
I'm reacting to it. I'm also looking at Carolyn's last comment that we're talking about health experts and organizations and like how do you actually change the decision makers? And I think that that's really I think that is the crux of what we have to figure out, right? And I think one of the things I'm thinking about is like we can opine on what the current situation is. The question is, what do we do about it? And sure, we can talk about patient-centered because that's what matters. I don't think it's going to move the heart and minds of the conversation, though. I think that like that is actually where the global health security agenda has been helpful, is that when you think about where the mix is, I think, to meet policymakers where they are today, so because that's what they're rooted in and they understand. And then you have to bring them out of that framing to what is possible. And frankly, though, you got to explain how it's going to be beneficial to them. And I think that one of the things when we worked with Peace Corps, for example, which was the roots of SEED, when we first worked with Peace Corps, we had to move some policy there. We approached them, and said, what do you think of doing this? And they sort of said, well, it's interesting. We actually are getting asked for more technical advice. We just have no idea how to do it. And we just methodically worked through the problems. We said, what are your challenges? And we will help you solve or think through the way that you can get through those challenges. And we would just stepwise work through that together. And in some cases, we push them to say, you just have to make this decision because it won't work otherwise. And all of our effort and money isn't going to get where you want to go. And we have to see how it goes. And let's reevaluate in 6 months with how it goes. So I think you have to, when we're changing the hearts and minds, you have to help explain how this is a win for them, right? These are elected officials often, or the policymakers are accountable to somebody. And you have to frame yourself with what are their pressures and how do we help them move through those pressures in a way that they can trust. They can not only do good, but this will survive, right? Or will do well, or help them see the picture of what they don't know. And I think the problem with health is that a lot of decision makers and policymakers that are creating the allocations and are making decisions, they're not in health backgrounds. And that's actually where, but we, frankly, a lot of doctors or nurses or health people can't also articulate the policy side. So somehow you've got to be able to link those two things. And I think and this is where we've had success with SEED, is pointing out that what we've been doing hasn't worked. There is a way to do it differently, and to take those success stories from Partners in Health, take Lola's success stories, take our success stories to explain that when you get to 8 years, this is what you can do. You can train a bunch of midwives in a rural place in Uganda, 100% of whom stay employed, 85% of whom are still in the public sector and who are delivering high quality care, right? We can do these things. But we have to be able to bring those examples forth and show the possibility.
We're running short on time here, but I want to make sure we get at least a final thought from Lola and Paul. Lola, what do you want to leave our group with here?
I think that for me, the most important thing is to understand that we're in a diverse world, and the term security needs to be packed for the moment and replace it with the term equity, poverty, and systems, so that we can bounce back, we can unlearn, relearn, and fix what we haven't learned well. I think that's very important for me. I also think very important for me to also put on the table the infodemic and the impact of that infodemic on policy global to local. Much of what we see in the shift for our well-intentioned health security to what we have today is an impact of the infodemic. The infodemic is also important because if you see how policy after policy is changing, it's because country voices are bolder on Twitter, they're bolder on TikTok, they're bolder. We need those bold country voices to be enabled to be even bolder, because nobody's going to lock you up on the internet. Nigeria is locked up Twitter, but we go VPN and we still continue to speak. And so we need to empower bold voices as part of this. HIV/AIDS would have got nowhere without bold voices. I'm going to leave lastly with a challenge to my colleagues who are civil society organizations. When you sit on the board of Gavi, on the board of Global Fund, don't become Gavi advocates alone. Don't become Global Health advocates, Global Fund advocates. Be advocates for people and speak out even when Gavi is not doing the right thing, when HIV is not doing the right thing. So we have lost the traction of civil society to speak out. And so we need to rekindle the traction of civil society to speak out, informed and evidence-based speak out. Thank you.
Thank you, Lila. Paul, a final thought from you?
Well, I'm just reading Carolyn's point. It's a humbling one for the reason Vanessa mentioned, that a lot of even the health activists, don't really know a lot about the policy. I mean, I was in medical school, and I bet it's the same for Lola and maybe even Vanessa, who was, some decades later, but we learned absolutely nothing about healthcare financing, insurance. I mean, I didn't even know that I was being paid by Medicare, which, again, not to be obscure for the non-Americans, Medicare is how we fund residency training. I didn't know that. So we come out really illiterate on a lot of very important topics. But to Carolyn's point, I don't think that we're focusing. I wasn't trying to focus on health experts or organizations. I was trying to say, and this is what Lola said, how can we focus on those most affected by whatever the problem is? Like, breast cancer survivors, people living with HIV. There's a lot more work to do to be more inclusive of people who've really been shut out of the dialogue. And I'm not suggesting it's an easy thing to do, but it's certainly not impossible to get more input from those most effective. And that would lead me to say, what are we doing here? Well, we're really having a discussion that is targeted to fellow elites or those way above us in terms of power or economic capacity. And that makes sense as well, because especially if we're thinking about any kind of redistribution of the world's ill-gotten, gains or well-gotten gains, I think we need to do more on the inclusion front and get more and better ideas in the way that Lola mentioned about having people feel free to participate in these discussions. And finally, I'm going to just say it again, as much of a slogan as it is, healthcare is a human right. It isn't a human right, of course, or we wouldn't be having this discussion today, but it should be. And these basic social securities are really the securities we need to be focused on, or this basic social security is the security we need to be focused on. And yet we're living in a world where still catastrophic illness or injury is the leading cause of, pauperization or becoming, destitute. So I think we have to keep going back to that rights-based framework. And I know I'm just echoing Lola here on this one.
One of the reasons I'm so excited that the Global Health Council put this panel together is because all three of you have really brought to your own work, your own careers, that sense of ambition, that sense of, as bad as things are, as tough as the circumstances may be, that's exactly where we ought to go. And you're not going to be held back. And I think we need that at this moment in the global health community more broadly, because many of us feel like, look, we thought this crisis would be the one, right? This would be the one that would suddenly shake the world, and we would see these big new investments into a global health system at the local level and at the global level, and it hasn't quite happened, right? And we're just actually seeing more of the inequities expanding and amplified during this moment. So I think we need your courage and your ambition that all of you bring to this. And I think that, while global health security may have worked, it may continue to work in some contexts, it's not an ambitious vision, is it? Right? It doesn't say, here's what's possible in the world, or here's the world we want to create. It really is a defensive vision. And so I think this conversation shows it's not easy to come up with that new, bold vision that is ambitious and that is hopeful, but we need to do that. And I think the Global Health Council is so right to gather this group and to put you here and put this topic here front and center. So it's great to be with all of you. It's great to be with all of you who participated in the comments. Thank you for a rich discussion, and really be well. And my thanks to all of you.
Thanks, everyone.
Thank you.
Yes,
Great
thank
discussion.
you.
Thank you.
Thank you, Raj, for your excellent moderation as always, and of course to our three panelists for your insights and thoughtful discussion. I'm Kiki Kalkstein, Director of Advocacy and Engagement for Global Health Council, just chiming in here for a quick announcement so all of our attendees know the schedule for the rest of the day. We know that everyone's getting used to the platform that we're using and hopefully enjoying navigating throughout that. So just to make sure everyone knows where we are right now, we'll have a quick break. But then if folks want to go to the event page, then on the left-hand side, you can navigate yourself to networking for the rest of the hour between 11 and 12. Between noon and 1, folks can feel free to take lunch or whatever break you have in your own time zone. And during that time, we will also be replaying Dr. Tedros, Director General from WHO. His keynote remarks will be replayed during lunch, so you can, during that lunchtime hour, so you can watch those remarks. And then our second plenary panel of the day is from 1 until 2:15 p.m. On the main stage. So that's the schedule. Thank you again all to our panelists for your discussion, to all of the participants for your comments and questions throughout the chat, and to you all for your participation in this year's symposium. Thanks all.
Thank you for having us.
Bye.